And just to show that this was not just a United States phenomenon, so there was a consensus statement that came out of a meeting in Australia. So, Dr. Quinn, can you educate us a little bit on the Melbourne Consensus Statement on PSA?
So this came from a meeting in Melbourne related to the World Prostate Meeting, which was there in mid-2013. And I think this revolved more around consensus statements about what we think we know. So we have what one might call level 1 evidence for screening that group of patients from either 50 or 55 through 69. And as we talked about, this is based on the European data, but there are some areas where there are questions. So in particular, the question of whether we should be doing a baseline PSA test early for men as early as 40 is mentioned in one of the consensus statements, and I think that's clearly we know from data from Malmo in Sweden, from the studies that have been done there and published by Andrew Vickers and colleagues, that we can predict future risk of prostate cancer. But we can't predict its biological activity, nor do we know whether intervention will make a difference. And so I think that the paradigm for screening is going to change. We have a group of patients where there are solid recommendations where we think screening works, perhaps between 50 and 69. And then, of course, there's the issue of what you do after 69. Can you stop screening in those patients, and should you? And will the patients agree to it? And then for the younger man who may be at average or higher risk, should he have a PSA at age 40?
That's actually, something that you said there is very relevant, and that you said average risk. And I think that's important for the AUA guidelines, as this talks about the average risk patients. So Dr. Abala had mentioned, that patient with family history or African American, those patients are not average risk, for which there's really not data what to do. So the guidelines don't necessarily, at least the AUA, don't necessarily apply to that patient.
Really, isn't it a question more of, an individual basis versus populations? I mean, as an individual, you may think that prostate cancer is beneficial and getting a blood test is beneficial to you. But when you look at population studies, that data, falls short. And so and that's why I think it goes back to if you're not at risk, you need to have these discussions with your physician to outline, a treatment plan going forward. And then if you are at risk, we do know that there are certain risk factors for prostate cancer, and those should be taken into consideration as well.
So Van, you're part of a large urology group in Atlanta, Georgia, and obviously the LUGPA organization has come up with their own sort of consensus statement, if you will. Can you summarize that for us?
Sure, I'll be glad to. So we have never said that the PSA test is a bad test. In fact, the PSA test is probably the best cancer test that we have in all of medicine. We use it not only to diagnose but to follow therapies. But we take a little bit of a different approach. We don't think we do a bad job as urologists in diagnosing prostate cancer. I think we do a great job. The problem is on the back end, on the treatments. Are we over-treating patients? And I think the answer is yes. So we need to better select which patients, once we make a diagnosis, which patients need treatment and which patients don't. And I think we try and dissociate between the PSA test and the treatment of prostate cancer. Moving forward in the next several years, as Dr. Friedland said, I think we need to develop better ways in determining which prostate cancers are indolent and which are not. If you look at the pre-PSA era, where approximately 25% of men, when they were diagnosed with prostate cancer, had already metastatic disease. Since the PSA era, that number is less than 10%. So I think the number of patients that present with metastatic disease or have locally advanced disease is going to go up if we stop using PSA as a marker in initial testing. And I think a prime example of that is we know from European data that the number of patients dying of prostate cancer has decreased since the PSA era. But we also know that we have overtreated some men with localized disease. But I think if you take a prime example, if you get a PSA test in a man in his 40s, and if you know it's less than 1, you probably don't need to do one for another 5 years. You certainly don't need to be doing annual blood tests. But if the same patient who's in his 40s, even if he's the average patient and he's not African American without any family history, if his PSA is above 1, I think some of us would agree that maybe he should have another PSA in about a year. Others, maybe Dr. Crawford would disagree and he'd be more aggressive in trying to diagnose this patient. But that's the position of LUCPA.
Dr. Crawford?
Well, you know, there's a number of points here. First of all, at least the word on the street that I heard when this all happened from the AUA is that a lot of urologists felt betrayed by the guidelines and also at the same time the U.S. Services Preventive Task Force. I think there's no question that you need to separate diagnosis from treatment. That's the big problem. Once patients are diagnosed, the train's left the station and they get something done, and that therein is one of the biggest problems. People often quote that we don't have any studies that show a benefit to early detection of prostate cancer, and in fact the PLCO study, which we were one of the 10 sites in the United States, D'Amico and I looked at some of the data and published this. If you eliminate comorbidities and screen men that are in good health, there was actually a benefit to prostate cancer-specific death. You know, I think the other thing is that we are now blessed with some things we didn't have in the past to help us determine who to treat, and it's called markers. We need to treat these people smarter, and we can do markers to say who gets active surveillance. We get a lot of lip service about active surveillance, but if you look at it, less than 8% of people get it. It probably should be in the 30 to 40%. I think what our approach has been this, is that, you know, mass screening is probably gone, but we got to embrace the men's health aspects of this. And PSA is not only a surrogate for prostate cancer, but it's also for prostate size. And our thought is you can give a lot of lip service to informed decision and things like that, but it's not going to happen in large practices and in family practice. So our approach is to treat PSA like cholesterol and blood pressure and things like that. You get the test and then you act on an abnormality. And if we did that in our screening population, or if our early detection population, we would probably only need to talk to about 25% of men that had a PSA, and we consider something above 1.5 abnormal. So I think we need to retailer and retool how we're doing this stuff. We don't, you know, family practice guys are now finding that men aren't coming in for early detection to see them for their cholesterol and things like that, and they're realizing what drove them in was PSA and prostate cancers. So I think we just need to embrace this whole men's health a little bit bigger, and PSA is just part of it.
No, I would absolutely agree. I think the Men's Health Initiative has been really needs to be more prevalent. We need to be more active in it, just like the gynecologists are oftentimes viewed as the primary physician for females. I think there's a certain segment that really there's a certain segment of men that really look to their urologist almost in the same fashion, and I think it's up to us to embrace that role, actually. So, Steve, let's just